Good morning, everyone. Welcome, bienvenidos. For those of you who want to continue in English, please stay put.
Y las personas que deseen escuchar la versión en español, por favor, eligen el idioma oprimiendo el botón en forma de círculo, donde dice español en la parte inferior de la pantalla. Gracias.
Again, welcome and good morning to all of our live attendees today. We are thrilled you are here to engage in this exciting webinar about the what and whys of integrated behavioral health. I'm Julie Chronister. I'm the host of our webinar today. First things first, a brief audio description of myself. I'm a white cisgender female, she, her, early 50s with light brown shoulder length hair, black thick rimmed glasses, and I'm wearing a black top and my background is blurry. I'd also like to acknowledge that SF State's campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. We further acknowledge that we work on the ancestral lands and waters of many other indigenous peoples and nations in our field work in the Bay Area and around the world. We're committed to ensuring this webinar is accessible to our audiences. Closed captioning is available in the closed captioning option at the bottom of your Zoom screen. If at any time your access needs are not met or become not met during this webinar, please send a chat directly to our host, our co-host. Access is always a work in progress, so we appreciate your comments, feedback, and support. I'm a faculty member in the Department of Counseling, the Clinical Mental Health Counseling Program here at SF State, and the primary investigator of this project. I'm working alongside my project co-investigators, Dr. Tiffany O'Shaughnessy, who is faculty coordinator of our Marriage and Family Therapy program, and Dr. Molly Streer, faculty in our school counseling program. I would also like to thank our graduate assistants, Ro Cordova and Chinui Igwe, who are both working hard to stay on top of technical issues, chat boxes, etc. This is a fourth of our 10 webinars sponsored by our Equity and Justice Focused Integrated Behavioral Health Counseling Project, which is fully funded by the Department of Health and Human Services, Health Resources and Services Administration as part of an award totaling $1.9 million. An additional couple things before we begin. If you are one of our HRSA stipend recipients or are interested in receiving continuing education units for your attendance today, please pay close attention to the announcements provided in the chat for sign-in and evaluation links. Reminder that this is a live recorded Zoom webinar. Therefore, the audience is not visible and the audience cannot turn on their video or audio. The chat function is available for comments, sharing of resources, supportive emojis, etc. To ask the presenter a specific question, please post your question in the Q&A function. Q&A will occur during the last 10 to 15 minutes of the webinar, so please post your questions in Q&A as they emerge, and the presenter, myself, will answer the questions. The presenter will answer the questions at the end of the webinar. If we cannot get to all the questions, please contact the presenter directly, and this information will be posted in the chat. It is with great pleasure today that I introduce today's presenter, Erica Gomes. I will hand it over to Erica now.
Hello, everyone. It is a great pleasure and honor to be here today. I want to give a quick description of myself so you can locate me. I'm a white cisgender female with short brown hair, and my background is I'm in a white room. So again, just want to extend gratitude to San Francisco State University and to students who are having me here today to speak on a topic that's near and dear to my heart, which is integrated behavioral health. And just want to kind of, give a note that, I see myself as someone who knows a slice of integrated behavioral health from my particular lens, which is that of someone who's worked in federally qualified health centers and community clinics for the past 20 or so years. And I obviously know integrated behavioral health from my particular positionality and my particular experiences and all the learnings that I have had over the years in working with patients in many different settings and clinics, and the folks who have brought me along and taught me the ways of integrated behavioral health. So it's a pleasure for me to share that with you here today. Let's go ahead and move to the first slide. All right, so here are learning objectives for the time that we have together today. I'm hoping that you'll, at the end of this presentation, you'll be able to name at least one, but hopefully many benefits of integrating behavioral health into primary care settings. Name 2 to 3 screening tools that are utilized in integrated behavioral health settings. And the third one is naming 2 therapeutic modalities or approaches that are utilized in integrated care settings. Next slide. All right, so I always like to talk about experiences as journeys. I think that helps us to conceptualize. And this particular journey that we'll be on today will take us through different aspects of integrated behavioral health. And again, just a note, there's so many different models and programs. So I'll try to keep things fairly general. And of course, it's a big charge to talk about integrated behavioral health in all of its depth in a short presentation, but I'm hoping this will get you excited about learning more. So we're going to start with some definitions and models of integrated behavioral health. And then we're going to move on to how IBH works on the ground. The next part is the IBH team itself and zeroing in, kind of highlighting the role of the IBH clinician. And lastly, we'll move on to the client perspective and what the experience might feel like from that client vantage point. So if you will, it's a bit of a zooming out and then focusing in as we go along. Next slide. All right, so I think it's important to ground us in a definition of integrated behavioral health, acknowledging that there might be different facets or different variations on this depending on where you're practicing. But at its heart, integrated behavioral health is the care that results from a practice team of primary care and behavioral health clinicians working together with patients and their families, using a systemic and cost-effective approach to provide patient-centered care for a defined population. And this care really is going to address many things. It'll address mental health issues, substance use issues, health behaviors, including their contribution to chronic medical illnesses, life stressors and crises, stress-related physical symptoms, just a variety of different presentations and conditions, all within the primary care setting. And I think it's important just in terms of terminology and semantics to really throw in a couple other terms here. So I'm generally going to talk about integrated behavioral health, and we'll say IBH frequently because it's much shorter. But folks also will use the following terminology. So primary care behavioral health integration, integrated care, collaborative care, and really referencing integrated behavioral health as being housed within whole person care. Next slide. All right, so here are some statistics that I find, and particularly useful in terms of talking about integrated behavioral health and the importance of integrated behavioral health. So the first one is that more than 65% of antidepressants are prescribed by primary care physicians, and yet depression screening does not occur in most practices. So that's a really, really high statistic. And the other thing to kind of point out here is that in a lot of these cases, there really isn't a titration or adjustment of medications based on whether the patient's improving and metrics aren't really being used in many cases. Only 41% of patients with mental health issues actually receive treatment. And to me, this is a really staggering statistic. And this is one of the major cases for integrated behavioral health. And we'll talk about in a little bit of what are some of those reasons why folks aren't making it to that treatment, even though it is being identified as a need in primary care practices. The next one is between 30% and 50% of patients who are actually referred by a primary care physician to outpatient mental health care never actually make it to their first appointment. So this reminds me of one of the first medical providers I ever worked with, probably a second or third week doing integrated care. I asked him, I said, so normally, where do you refer folks for behavioral health? He's like, oh, I refer them to X clinic down the street. I give him this little handout. And I'm like, okay, well, what's your success rate? Like, how many folks actually make that connection and see the clinician at that center? He's like, yeah, I probably have a success rate of like 5%. So his statistic was much different. And the last one is compared to routine primary care, enhanced primary care behavioral health services deliver superior health outcomes for many, many conditions. And some included here where there's a lot of research that's been done is around chronic pain, diabetes, obesity, alcohol abuse, tobacco use, depression, generalized anxiety, social anxiety disorder, and panic disorder, although there are many more conditions where that augmented care is going to result in better outcomes. And this makes a lot of sense to me because really with integrated care, you're looking at the whole person. So what you're doing is you're also able to weave in the contextual factors to what is going on with a patient medically. So maybe there's stressors that are happening. Maybe they have things that are happening in the family that are contributing to their ability to manage their diabetes, for example. And so really bringing integrated care in, we're able to see the whole person and really get a sense of what are the different layers that are impacting the medical conditions that they're diagnosed with. The next slide. All right, so this is a visual, just kind of like a little Venn overlapping circles. And the part I wanted to focus on here is really this overlap. So there's this just a statistic that 68% of individuals with mental health disorders also have medical conditions. And the bottom, which is a third of the adults with medical conditions, also have mental health disorders. So oftentimes the system traditionally has really separated these two lines of treatment. So you'll go over to your primary care provider really for all the physical health issues that are happening. And you'll go across town to your mental health provider for all the mental health conditions that are happening. But reality is we're seeing one and the same person. And there's so much overlap. And I would argue that some of these statistics should probably be higher depending on the population that you're working with. So this idea of integrated health is really just to say, if we're really talking about the same person, maybe it makes sense to provide those services in the same place. Next slide. All right, so we referred a little bit to that difficulty that the provider I worked with had in terms of referring patients to that specialty service, and what were all the things that got in the way. So these are just a few, just to name a few barriers, but I imagine that all of us, if we stop to think about all the challenges that might be there for patients and for ourselves in accessing care in a different system, we might come up with many more. But the ones that I frequently see are transportation barriers. So particularly in some of our clinics that are a little bit further out, in areas that aren't so urban, that don't really have really robust transportation systems, that might be a reason why folks aren't getting to those services. Again, distance from your home, distance from the clinic itself. Stigma is a huge one. And we've seen this time and again, that the minute a provider might talk about needing to access behavioral health systems, folks, and especially folks who maybe have had negative experiences or have family members who've had negative experiences accessing mental health care, will all of a sudden, kind of disconnect and not want to access that based on stigma that exists with accessing those systems of care. Language and language capacity at different systems. So for example, maybe they go to primary care and the primary care provider speaks their language, but they have really a lot of challenges accessing other systems of care because of language capacity. Having the time and just in a really busy schedule, folks are working, folks have kids, folks have competing demands on their time. So accessing something that's unfamiliar to them and prioritizing that in life might be really challenging. And really this last one, I think for me, is just really hits home. The fact that we're really describing a service sometimes that folks aren't familiar with at all. And so really trying to conceptualize what it would be like to go to this other place to talk to someone about something really personal, something that they've struggled with a really long time, that in and of itself can be a huge barrier. Next slide. Okay, so there's this framework that's called the triple aim and quadruple aim. Actually, it's been updated. So the triple aim has been developed by the Institute for Healthcare Improvement, and it's really about optimizing healthcare system delivery. And so when we're talking about integrated behavioral health, kind of housing it within the quadruple aim and seeing like how would integrated behavioral health really meet the needs or fulfill the needs of the quadruple aim. So the quadruple aim really looks at how can we achieve better health outcomes? How can we achieve improved patient experience? How can we achieve improved staff experience? And all while lowering the cost of care. So it seems like this like really ambitious thing. But really the case for looking at integrated behavioral health in this context is to acknowledge that, you know, as I mentioned before, you really will have better health outcomes if you're providing more services in-house. So if you're able to take a more holistic approach to a medical condition or comorbid condition, maybe an individual has diabetes and they also have depression, and those two things are interacting in ways that are impacting the outcomes of both of those conditions. Bringing in integrated behavioral health might actually improve those outcomes. Improve patient experience. If a patient is able to get all those things in one place, that one-stop shop concept, then that's going to save them time. It's also going to really help them to understand how their health is looked at in a more holistic lens. So if the minute they start talking about depression, that has to be outsourced at a different clinic, then the message to them might be that my medical provider actually doesn't want to talk to me about this, or this isn't part of my care here. Improve staff experience. So, and this is kind of what is added, the fourth component of the quadruple aim that was added later. And this is really about looking at how does integrated behavioral health in this case really improve the experience of staff and providers. And there's definitely evidence that shows that providers feel less burnt out and more engaged when they have a team of folks who are working with their patient alongside them. And there's also just like cross-pollination of learning when folks are in the same room and multidisciplinary teams come together to work in service of a patient. And then the last part is just lower cost of care. So definitely if we have an individual who's receiving all services in one place, that in of itself could decrease the cost of care, but also integrated behavioral health. There's a lot of statistics that show that folks who are engaged in integrated care have less hospitalizations, less institutionalizations, also have less frequent medical visits because some of their needs are being taken care of with the behavioral health provider. Oh, and actually, before we move to the next slide, I just also, the reason I put access off to the right is in thinking about like what are the ways that we're measuring a successful program, really for integrated behavioral health practitioners, the huge thing that is always coming up for us is access. So we're always coming back to the table asking, how can we ensure that our patients have the best access possible? How can we strategize our workflows so that we're really always providing open access to our patients, because that's a huge priority and goal for integrated care. Next slide. All right, so now I'm moving into just different models of care. And again, I'm giving the caveat that here's some types of models, ways to kind of orient and ground conceptualizing integrated behavioral health care. And quite honestly, a lot of programs are really blends of some of these models. But just to name a few, the first couple, I was really excited when I came across these. I had been in integrated care for some time. And then when I read about vertical and horizontal integration, it just made a lot of sense to me. So one way of looking at programs, program development is your program centered around a vertical integration approach? And so this means that you're focusing on kind of one condition or one presentation, and you're really clustering all your resources around that. So for example, our clinic is kind of a routine clinic, but we have integrated care for all individuals who are diagnosed with diabetes, for example. And so what that might look like is there's panel managers and they're tracking outcomes of individuals who are receiving diabetes treatment. There are behavioral health clinicians clinicians who are working specifically with patients who have a diabetes diagnosis, and the care is clustered, the teamwork is clustered around that diagnosis. That's vertical integration. And then the other concept is horizontal integration. And that's really where a clinic has integration across conditions and across populations. So any individual who walks into the clinic, regardless of age and regardless of their diagnoses, has an opportunity to have access to integrated behavioral health providers. So many of the programs tend to be a little bit more horizontal integration, with the exception of sometimes they specify age groups. So some do all ages and some are really focused more on adults. And then kind of jumping over to the right side, these are more kind of conceptual models. And so the first one, which is primary care behavioral health model or consultation model, this was kind of one of the first models of integration that was out there. And really it relied heavily on psychologists who were trained in the health psychology discipline. And they would come in and they would really be embedded and housed right in the primary care space. And they would do a lot of co-visits and a lot of quick consultation, maybe like 15-minute consultation with medical providers. And their visits were pretty much just embedded in that setting. They typically didn't have a lot of standalone appointments, and they would just be available on call all the time. And that was more of a consultation model. The next one is a co-location model. And this one, there's a lot of grants that were built around this. And so the grants would look like approaching a specialty behavioral health clinic and having a few of those folks go into the primary care settings and kind of set up shop there. And so that was great because there was some cross-pollination happening. We really reduced those barriers about transportation and access. And then some of the, kind of not complete parts of that model was that the treatment plan wasn't necessarily shared with medical. And oftentimes the documentation would be still separate. So it's kind of like moving a little bit more towards integration. The next model is just to kind of call out collaborative care model. So a really good example of this is some of you might be familiar already with the impact model, which was a model that specifically focused on older adults with depression. And so that is kind of an example of that vertical integration. And a care team was really, a collaborative care team was formed around individuals who qualified for that diagnosis of depression and above a certain age. And there was a lot of metrics used, a lot of panel management, and a lot of really co-managing of patients within that model. The next one we're going to talk about in just a second, so I won't go into it too much, but it's traditionally known as reverse integration. I think there's probably a better name for it now, but it's basically where you take primary care providers and you actually outstation them into specialty mental health settings. And then the last one, which I particularly always want to highlight when I talk about integrated care, is this hybrid or blended model. So for me in particular, when I started in integrated care, there were just not so many models out there. And I would read about a model and be like, oh, that's really cool. But this thing I don't think is a really good fit for our population, or this piece I'd want to tweak a little bit, So one of the things I really want to highlight is that whatever model you're using, it needs to really be a model that's responsive to and reflective of the population you're working with. So I think it's a wonderful thing that integrated models look very different depending on where you go, because that's kind of the spirit of it. You really kind of need to do what works best for your population. And so that's where I kind of highlight and want to uplift the hybrid or blended models. Next slide. All right, and so SAMHSA, actually, there's a link in the notes at the end that I'll provide for you all. But SAMHSA has a really great, it's called the 6 Levels of Integration handout, which you might be familiar with already. And it's basically a reference tool that agencies can use to kind of see, like, where do we fall on the continuum of integration and where do we want to set our goals? So we might be doing really good integration in this clinic, but this other clinic might need to work more towards integration in these ways. And so it's really nice because it kind of gives some bullets around, like, what does that look like at each stage of integration? And it's separated into kind of 3 core levels of integration. So there's the collaborative, the co-located, and then there's the fully integrated systems. And that's really where Everything's integrated from the front door to the back door, medical records, all staff are on board and aware and supportive of the integrated model. So just want to kind of say, that that integration can really shift depending on the clinic, depending on the specialty, and depending on grants and like who's funding the different integration levels. And it can really move and change depending on the clinic. And then, one agency within actually might have various levels of integration. So what that might look like is you have a primary care clinic, but there's special Ryan White funding to do integrated care for individuals living with HIV and AIDS, for example. So some departments might be fully integrated and others might be kind of on the way to integration. And then also just to kind of highlight again that really the level of integration that you choose really needs to be reflective of what those needs are of your population. So let's go to the next slide. Okay, and I mentioned this a little bit before, but we're kind of circling back to this concept of the reverse integration. So this was an older model. It was called the four quadrant clinical integration model. And basically what this says is when you're really looking at the population that you're working with, you're going to identify that they may have high behavioral health needs or lower behavioral health needs, high medical needs or lower medical needs. And based on where they fall on that quadrant, you want to design a program that's going to be most responsive to those needs. So you'll consider also what system of care you're working in, what the limitations might be, and then kind of design your program to best fit the needs of the population. So for example, you might be working with a population that has a high number of individuals living with severe and persistent mental illness, and they may conversely have lower medical care needs. And so that might be a situation where you would leverage your resources to bring in some medical care providers to that setting that can do some monitoring of medical symptoms, given that the individual's greater need would be around the behavioral health treatment. So that's just one example. Next slide. All right, I always like to take a little pause here just to say we've been talking about all the wonderful things about integrated behavioral health, but also just to kind of take a step back and really situate IBH in the larger system of care. So IBH is amazing, wonderful, love it. And it really is just one piece of the puzzle of the larger system of care. So really IBH was kind of conceptualized and born out of this need to really fill the gaps in the system of care and really address preventative needs that are coming forward. So not really to replace any of the amazing work that's already being done by our colleagues in the specialty behavioral health realm, but really to ask the question like, hey, what would it be like to catch folks on the earlier phases of having behavioral health needs? And also, who are those folks who have maybe even moderate to high behavioral health needs, but aren't getting to those systems of care? How can we bring in some supports to fill those gaps? Next slide. All right, so this is a visual, just a triangle kind of separated by different segments. And really when we're talking about who are the target population for integrated behavioral health care, again, it's going to be very unique based on your program, but in general, integrated behavioral health really seeks to provide services to individuals who are falling in the mild to moderate behavioral health presentation. And so, that's very subjective and that really can vary depending on your population. But the folks that we're looking to provide what we refer to as a course of treatment to are really folks in those mild to moderate levels. What you'll also see too is because integrated behavioral health is housed in the primary care clinic and the medical home of individuals, we're really seeing everybody. So it's not that we will never see someone who's presenting more in the moderate to severe levels, but we're really seeing everyone. But the question we're asking is, who do we need to support linking out to those higher levels of care, and who would we keep in-house for a course of treatment? And so this kind of visual helps me anyway to conceptualize like who's falling in that that upper third, and then who do we want to focus on for the lower 2/3. And we have a lot of flexibility in the programs I've worked in. There's always a lot of flexibility around this because we absolutely acknowledge that there are real reasons why folks may never get to specialty behavioral health. And so the question is, how can we best support them and support the efforts of their primary care provider and managing their care in the primary care setting for those situations. The other thing I really want to pause and acknowledge here is that we're really talking about levels versus people being fixed to any one part of this triangle. So in the spirit of recovery and wellness, we really want to think about individuals as really traveling on this triangle. So there may be times in an individual's life where they're kind of more in the mild to moderate presentation, or there are times maybe in crisis or significant things happen and someone might be needing more of a crisis stabilization approach, and they'll be more in the severe realm. Next slide. All right, and so that's a great kind of intro, I think, to stepped care. And so stepped care is something that we talk a lot about in integrated behavioral health settings. And it's really saying that we're, really hoping to continuously ask the question and assess, where is this individual in their treatment of depression or anxiety or whatnot? And, are they in the appropriate level of care for what their current symptom presentation is? And so we really want to kind of be thoughtful about the resources and how an individual is moving through the system of care. And so we'll talk a lot about stepping individuals up to a higher level of care or helping them step down to a lower level of care, and really being efficient with resources and thoughtful about how we help folks move through the system of care. So it's really a fluid process that does require a lot of assessment and reassessment, monitoring of symptoms, and really looking at what are our workflows and how do we collaborate with other agencies in terms of supporting our patients at those times when they need to step up to a different level of care that we don't provide in-house. And really for individuals who've completed their course of treatment and met their treatment goals and are really ready to step back down to primary care with maybe just a medical provider managing their medications, how do we help facilitate that individual stepping back down into primary care settings? Next slide. All right, so now we're going to move to how IBH works on the ground and what it really feels like and looks like. So just to kind of call out a few aspects of the general structure, we talked about our target population is really mild to moderate, and that's target for treatment. And then, I kind of say this, joking but not joking, but we're not really opening cases, right? And so every integrated program looks a little different, but in the practices I've been at, we don't really talk about individuals as cases we open and cases we close, because we really feel that we're part of that medical home. And so folks are coming in all the time. We're not starting and ending treatment per se. Now, there will be individuals that we're having a course of treatment with. And so we might say we're meeting them today. And because it seems like a good fit, they're interested and want that treatment, we'll meet with them for 8 to 10 sessions. We might say goodbye for now, but they're still going to kind of keep seeing their medical provider in the place that we work. And so they might come back into our care at another point in time when they're needing that level of care again. And then for folks who we're assessing to have maybe in this current moment some higher severity symptoms of behavioral health symptoms, our role then becomes supporting their linkage to that specialty behavioral health setting. Again, I mentioned that episodic care. We do a lot of crisis support because oftentimes folks will come in to trusted individuals when they're in a crisis, and that might be their medical provider. And so we help them at those times. And then this last piece is really just kind of conceptualizing our care as intergenerational and over the lifetime course. So our clinicians who've been with us for many years will have had the experience of working with folks maybe in one particular setting at one particular time, and then a couple years later they come back and they work with them again because something new has come up. And also very commonly we'll be working with different members of the family and and intergenerationally. So maybe we worked with the grandparent and now the parent, and then they've had a child and now we're working with them in the pediatric clinic. So that's a big part of, I think, community clinics in general in our care. So next slide. And who's on this team? So very intentionally, the patient bubble is bigger and it's in the center, because really our patients, our clients, members, however folks refer to them, they're at the heart and center of our team. So really it's that concept of, nothing done for us without us, and we're always involving the patient in their own care. Other members of the team, folks will be familiar with: the physician, the medical provider, the nurse, the medical assistant, more kind of on the medical side, our behavioral health clinicians, and really that can be many different disciplines. So I mentioned before, psychology, licensed clinical social workers, marriage and family therapists, a lot of interns providing this care, really just an expansive view of behavioral health clinicians. And some other folks I really want to highlight on this team that are really integral parts of our team. In some places in integrated care, we have a specific medical assistant who's devoted to integrated behavioral health. And so in our practice, we call this an IBHMA, or integrated behavioral health medical assistant. And this person is seriously the linchpin. And so what they do is they absolutely manage our schedules. They interface with patients for reminder calls. They actually explain the services to patients over the phone just to make sure they understand what they're coming in for. They know our patients really, really well. And they can really help do kind of soft triage when patients are reaching out for appointments, and really help us figure out who needs to be seen more urgently, who can wait for their next appointment. And they're just a phenomenal resource for our team. So it's a really important person I just kind of want to lift up. Our front desk is absolutely significant in our care. I just had this happen the other day where I was really trying to get a hold of a patient who had expressed some risks to her primary care provider, couldn't get a hold of her, mentioned to the front desk person, hey, if this person calls, patch her through, I'm really trying to get a hold of her. She said, oh, just 1 minute. She's like, gets on the phone and texts her. And within 5 minutes, I was on the phone with this patient. So never underestimate how well the front desk may be integrated into the care, and what a great resource that can be for us. And case managers. So we have been really gifted with some amazing case managers who are experts in navigating our very, very complex systems, and really focus on those social determinants of health, and can really bridge a lot of the linkages that are so essential and vital for our patients in engaging in care. Next slide. All right, so I'm going to talk about some core components of IBH. The ones that are in green, we're going to take a little bit more of a dive into. So universal screening is something that happens very commonly in integrated settings. We're going to talk a little bit about the warm handoff, which some of you may be familiar with. It's kind of a hallmark of integration. We're going to talk a bit about how we do assessments, touch on evidence-informed treatments, and other components that are part of IBH. We won't probably go into great detail today, but the concept of shared medical records, the fact that we're all documented really in the same electronic health system, and where there's a lot of bidirectional communication in that. We're focused, integrated behavioral health is really focused on population-based care. As I mentioned before, we're really looking at what are the needs of our particular population and how do we leverage our resources. For example, what are the groups that we need to offer that are really going to be most helpful for our population at this point in time. And the last one, just really focusing on social determinants of health. Next slide. All right, universal screening. So why universal screening? Why behavioral health screening? So really focusing on screening for detection, for prevention, and for intervention. So it's really helping us identify who are those patients who really might most need the behavioral health support at this point in time. So if we're talking about a whole population of patients who are coming in and out every day, really just having a way of identifying who actually might be struggling and who might benefit from these services. Behavioral health screening really helps us triage the need. So who needs to be seen more urgently if we have maybe a longer wait time. Over time, it's an ability to track symptoms and progress. So for example, if you're using a depression screen, that can be re-administered, and we can use that to help us determine the outcomes of a certain treatment that they're receiving. It's a practice standard, so it's kind of a language that is spoken by all in behavioral health care. So if I'm giving a number, PHQ for depression scale, giving that number communicates something to the medical providers, and we have that shared language. It can actually be a psycho-ed tool for patients, which is really great. A lot of the screening tools that we use are very closely mapped to the diagnostic profiles for depression, for trauma. So we can then flip that around and use that as a psycho-ed tool for our patients. And also it informs some of our diagnostic decision-making. So next slide. All right, so in federally qualified health centers, many health centers, there are guidelines that mandate annual screening for all patients, all adults, particularly for depression and substance use. So just wanted to kind of highlight those two, because that's happening on the regular for all patients annually. So for our adult patients, where typically most practices are using the patient health questionnaire, or the PHQ-9. It's a 9-item screener. And for adolescents, there's a slight shifted one. The wording is slightly shifted, and that's called the PHQ-A. For substance use, there's kind of a variety of tools out there. We particularly use the UNCOPE Plus. Other practices will use the Audit or the DAST. And then for adolescents, there's a specific screener that's called the CRAFT, and there's a bunch of different variations, but the latest one is a CRAFT 2.0 plus N, which asks about nicotine, particularly about vaping as well. Next slide. All right, I just wanted to call out a few additional useful screening and assessment tools that we use in our practice. For trauma screening, we're using the PCPTSD. In some places, we're using ACEs. For anxiety, the GAD-7. Relationship safety, it's called the HITS. It's a 4-item screener. And in some of our clinics, based on populations, we're asking some additional screening questions around access to services for newcomers, panic symptoms, and psychosis. Next slide. Okay, so the screening flow basically looks at, it all starts on the medical side, and that's the medical assistant administering the screening, and then the medical provider will review the results of the screening, and then the medical provider will discuss those results and may introduce in IBH services, and that also may include a warm handoff if available and if relevant. Next slide. All right, so warm handoff, this is kind of, as I mentioned, a hallmark of integrated behavioral health. But at its best, a warm handoff is essentially, I like to talk about it as an extension of that relationship between the medical provider and the patient. So many patients have worked with their medical provider, in some cases over decades, right? They've built up a lot of trust, and there's just a really wonderful working relationship. And so when the medical provider identifies that there may be a behavioral health need, they can really couch that conversation in that spirit of trust and kind of extend that to say, hey, I have this person on my team who's really great at working with individuals who, are experiencing X, Y, and Z. Would you like to meet her or him, or them, and bring them in? And so it really has a way of destigmatizing that care. It really has a way of kind of like, it's in a way like a push-in that we're doing, like a push into medical care. And I do want to emphasize at the bottom part here that it really is, we're really also trying to highlight autonomy and choice. And so we really, in all of our co-training with medical providers, will say, it needs to be, even though you think it's the most fantastic service, it also definitely needs to be an option choice that the patient is making. So we also couch that into the warm handoff. Would you like to meet them today? Would you like me to just let them know that you're open to a phone call, that kind of thing. So next slide. And this is a very wordy slide. I basically am just going to highlight that when the clinician meets with a patient, we really are doing a biopsychosocial, spiritual, cultural assessment, and just really want to highlight that we're really trying to see this individual's particular experience embedded in the environment and embedded in the family and the community that they're coming from. So we're going to ask about a lot of those things to get a fuller picture of symptoms and functionality of the patients that we're meeting with. Next slide. So these should be familiar to many of you. These are basically kind of the core modalities we think of that we use in integrated behavioral health practice settings. And just a caveat here is really any modality that we're using really needs to be adaptable to that primary care setting. So what that looks like, is somewhat briefer visits, also visits that may be spaced out to 2 or 3 weeks. We're not typically seeing folks, unless we have really high access, we're not seeing folks on a weekly basis. So we need to use a modality that's really flexible and that's adaptable, and also adaptable to the population we're working with. So at the very bottom, I also included here cultural adaptations to modalities, because we actually call this out in our practice. And we say, it's really just acknowledging that many of these modalities were not developed for and with the populations that we're serving a lot of times. And so we just want to be really cognizant of that. And so we may be delivering a modality and a language that it wasn't developed in, for example, or we may be really making adaptations to be more inclusive of family work or community strengths and resources. Next slide. So just want to kind of highlight a couple things here in terms of integrating practices. I think also just to not lose sight of the fact that we're primary care and behavioral health, we're trained in many different ways still. And we also are kind of coming from different spaces many times. And so just to kind of highlight, at its best, integration is really bringing that multidisciplinary skill, those different skills to the table, and a perfect marriage of service delivery. And sometimes there's some bumps in the road because we're trained differently and we kind of approach things in different ways. So just to kind of call out a few of those, pacing might be really different. Documentation practices and the way we've learned documentation might be really different. The fact that we might be more process oriented or concrete solution focus oriented. We might have differences in the way we conceptualize a referral question or a key question, clinical question. The way we emphasize autonomy might be slightly different, right? And based on, obviously, if someone is facing some pretty severe medical needs, then, we might struggle with like what level of autonomy is being messaged. Using screening tools is vital. So sometimes folks can over rely on screening tools, and when particularly it might not be as useful based on the population that you're working with. So that might be that. And then I just want to call out also mitigating factors. So what do we do when these things come up, right? How do we try to streamline our communication as best as possible? Offering up spaces to debrief when we have kind of challenging conversations or things that come up that highlight differences in practice. Having huddles that we check in with each other regularly, or consulting with each other. And really some way of like sharing that knowledge across the table. So do we have grand rounds, or are we doing case conferencing, and really just highlighting the shared learning? So, next slide. Okay, so I'm looking at time, and I'm gonna just kind of highlight this patient, I think, really quickly, because I do want to leave a few minutes for questions. So this is just really patient perspective and how they move through the system. So I'm not going to read the whole description, but this is basically an adolescent clinic who accessed, or an adolescent patient who accessed our clinic, who is a recent immigrant from El Salvador. And she basically came in just for immunizations because she's starting school. And so as she's being roomed for that medical visit, the medical assistant is providing her with a screen for depression, substance use, and trauma. And she ends up scoring high on depression and trauma screens, and the medical assistant alerts the medical provider. So we'll go to the next screen. And so this is just kind of calling out, this might be some of the things that this patient would hear. So from the medical assistant, she might hear, hey, we provide this screen for all of our patients. This screen asks about different aspects of your health. Only fill out what you feel comfortable to share today. And from the medical provider, she might hear, I'd like to talk to you about your responses to these questionnaires. I work with someone who specializes in trauma, for example, or specializes in, has worked with a lot of folks who have recently arrived. Would you be interested in speaking with them? And then what they also might hear from that medical provider once they're together with the behavioral health clinician in a warm handoff is, hey, Diana and I have been discussing X, Y, and Z. We're hoping you can help her with X, Y, and Z. Next slide. And then on the back end, once that warm handoff happens, the clinician will then meet with Deanna, and then we'll conduct an assessment, maybe even crisis intervention if needed, explore options for treatment. And then closing the loop, the integrated behavioral health clinician will loop back with the medical provider, either through the EHR, electronic health record, or face-to-face if they have a moment, and just kind of talk about what that visit was like and what care might be provided from that point on. Next slide. Okay, I'm not going to spend a lot of time because I want to open for questions, but just kind of wanted to, also just say there's a lot of work that's being done in our primary care settings and our integrated settings to really look at our practice through new lenses, right? And really rewrite the narrative in which we work. So I think everyone who's in primary care, say everyone, most of us are acknowledging that many of our communities have a challenging history relationship with primary care, just based on things that have happened over the years, and definitely looking at and analyzing and really asking questions about, are we providing full access to all individuals equitably? Are we aware of the ways in which our systems are built, more in oppressive, couched in oppressive structures? And what can we do? What action steps can we take to change that, right? Really looking at trauma-informed practices and seeing from beginning to end, or all of our services really truly holding trauma-informed practice models, right? So that inquiry, I think that's really happening in a lot of our spaces. And I think integrated behavioral health is a great nexus to be able to hold those conversations. So just kind of wanted to end with that really quickly and open for questions. But I've offered up some references as well, just like for further reading and just to explore and dive into integrated behavioral health. And I'm just so happy to talk with anyone further if you have questions about anything I shared today or in integrated behavioral health in general. So again, wanted to just extend gratitude for y'all for being here and for inviting me to join you today.
Apologies. I'm trying to show my video. Erica, thank you so much for this amazing presentation. And apologies, I am just a second here. Okay, thank you so much. It was an incredible presentation. And I just want to acknowledge that somehow I did not do the most important part of our introduction today, which was talking about you. And I want to just give a brief, I did ask my co-host to post in the chat your background, but I know it's a little after the fact, but if you don't mind, I would like to share with the audience who you are and your background. Because we're so grateful for your work today. You are a licensed social worker. You've been in the nonprofit sector for over 20 years. You started your career as a domestic violence counselor. You've worked in primary medical settings to a variety of populations, in community health centers, providing bilingual services and implementing integrated behavioral health model across these communities. You're also providing psychotherapy on a sliding scale, mental health evaluation for asylum cases, and has worked internationally, providing social services in Central America. I also understand you're an exam writer for social work's licensing exam. You've done research around best practices in group CBT interventions for unaccompanied minors. And also you're a field consultant, do field consultant work and teaching at UC Berkeley School of Social Work. And currently you are a lead integrated behavioral health supervisor at La Clinica, where you supervise a team of clinical social workers who provide integrated behavioral health at several medical school clinics. throughout Alameda, Solano, and Contra Costa County. Apologize. I know this is a little backward, but I did want to acknowledge all the amazing things you're doing and how grateful we are to have you with us today. We do have some questions that I'd like to throw out. First question is there a specific or unique way the integrated behavioral health model works within a school framework?
Oh, that's a great question. And yes, I mean, there's many different models within the school framework, and I'm really excited to actually plug an upcoming presentation, I think in the spring, by some of my colleagues who are embedded in school-based health centers. So yeah, essentially, just a real quick description is it's taking kind of a large clinic and shrinking it down and plopping it into a school setting. And so what that looks like is generally the clinic will get consent from parents and guardians on the front end during the registration process that will allow the youth to access the clinic at any time during the year. And so youth can just drop in and they can get sexual reproductive health support and also meet with any of our clinicians who are there. So usually there's maybe like 1 to 2 medical providers, a behavioral health clinician, a health educator, an MA, and yeah, they can access full services there, which is phenomenal. And going back to that concept of access, that is like 100% full access. So yeah, it's a wonderful model, and my colleagues will be presenting more on that in the spring.
Yes, plug for that. We have 3 colleagues coming in, I believe, March of 2022, who will talk about school-based integrated behavioral health. So we'll have that on our website. Thank you. Another question: what differentiates integrated behavioral health from community mental health?
It's a great question. So in general, and I think sometimes different terms are used flexibly, so that gets challenging. But in general, when we're talking about community mental health, we're talking about programs that are funded by the county generally to provide behavioral health services. So things like early prevention, detective screening and treatment, so EPSDT programs, your community mental health contracted agencies, outpatient mental health clinics, for example. And so what we kind of term as like specialty behavioral health. So typically there's some criteria that's met for individuals to be able to access that level of care. So it could be, in some senses, they have a DSM diagnosis. In others, it could be that they need to actually have a more, moderate to severe symptoms to access care there, because obviously they're being mindful of the resources that they have. And so integrated behavioral health is really looking at providing services to folks who don't qualify for specialty. So folks who maybe have more mild to moderate presentations, or the other thing to mention is we're in the Bay Area. It gets really easy to be in that bubble of like more robust systems of care. But I have colleagues that work in more rural settings, and there's virtually no county system. There's like no behavioral health specialty treatment. And so a lot of the care, pretty much virtually all the care, is happening within these integrated settings because they really just don't have other resources. But in general, that's how you would separate those two.
Thank you. If you have time for another question, I think we have 2 or 3 minutes left. How can school counselors effectively partner with school-based integrated behavioral health clinics? For example, do you have recommendations for their roles in screenings, referrals, partnerships, etc.?
Oh, that's a great question. So it can look like many different things. And so what our school-based behavioral health clinicians tend to do is they're housed in the clinic, but they're also active members of that school community. So they're participating in those coordination of services, treatment, the cost meetings. And so at that cost meetings, they're at the table with other behavioral health providers that are contracted into the clinic, or maybe even other behavioral health providers that are funded through the district itself. And so when they're around that table, everyone is, kind of having a conversation about like, who does it make most sense to see this individual, right? So is the youth needing weekly therapy in the sense that they would probably then leverage the resource of the community mental health person who's outstationed at the school? Or is this someone who just kind of needs some, maybe there's adjustment issues, stress reduction? That might be someone who's more appropriate for the integrated behavioral health setting. So the cost in schools, particularly, that cost team meeting is phenomenal and amazing. Now, if you're a school-based behavioral health provider who then wants to coordinate with the primary care clinic who also might have integrated care, that's a really great space to kind of ask about. And so I know for our integrated behavioral health clinicians who aren't at school settings, we're really trying to learn for the particular district that we're working in, which schools have those resources and how we can partner with them through like release of information so we're able to have fluid communication, because we really want to make sure that if it makes more sense for this youth in front of me to be seen in the context of the school setting, because maybe it's safer for them or they don't want to involve the parent guardian in the treatment, then we would want to leverage that and make sure that that youth gets connected to that service. So it's a great question.
Well, it's 11:31, and I just want to take this opportunity again to thank you so much, Erica, for this terrific presentation with so much good information. And I really also appreciated the questions about school-based integrated behavioral health, because that is a nice segue into our spring. We have 2 webinars that focus on systems change and school-based integrated behavioral health, as well as clinicians talking about what they're actually doing. So I just want to, we're really grateful for your work today, Erica. And I believe there was a question about contact information for you. We have that posted in the chat. And if anyone has difficulty, please don't hesitate to reach out to myself. I can be sure to pass you along to Erica. So thank you so much.
Thank you.
And thank you to the audience for being here today. And we look forward, don't forget, we have one in January on outcomes. So please join us then, and everyone have a good December.
Thank
See you in the new year.
Take care.
Take care.